Right. You guys can see the slides now?
Yes.
Yes.
Yeah. Okay, I have you guys on another device as well, so I can see more of you rather than just on one device, but it still wouldn't allow me to see all the class. So I'll still ask you to participate verbally as well and or type in the chat box. All right, so I believe this is where we left off the last time. We're talking about Miss Isby, our fake patient that we've been experimenting on her with enteral nutrition, then parenteral nutrition, and calculated her caloric needs and all that good stuff. Does anyone have any questions about the material so far? No, I'm seeing a lot of shaking hands, shaking heads. Okay. So, just to summarize what we did when we picked up parenteral nutrition last lecture, we talked about what are the indications of parenteral nutrition, what are the contraindications of parenteral nutrition, the ingredients, macro and micronutrients. We'll do a little bit of math, then we'll jump into the complications, the metabolic complications of parenteral nutrition. So, SPE's basal metabolic panel now shows the following labs. Her sodium is 144, potassium is 3.5, and her phos is 2.3. You guys remember or have learned the lab values, the ranges for these things, or have not? You have. Okay. So is the sodium good or bad? Well, you guys said that you learned. So normal sodium is 135 to 145 or 147, depending on who you talk to or what literature you're looking at. So it's normal to closer to the higher end. Potassium is about 3.5 to 5 or 5.3. So it's normal on the lower end. And phos is about 2.5 to 4.7 or 2.7 to 4.5 or 2.5 to 4.5. You'll see quite often these ranges are slightly different from one piece of literature to another. But the key here is that the phos is low. Sodium is normal on the higher end, and potassium is normal on the lower end. So if you recall from the last lecture when we talked about these anions and cations don't live by themselves, right? They're bonded to each other. So if I want to replace the phos because it's low here, I'm going to have to give the phos with something else. And it's typically available as a sodium phosphate and potassium phosphate. In that case, it would make sense that I would use potassium phosphate, right? Because I'm replacing two things with just one vial. So based on that, the question continues. Based on that, you decide to add potassium phosphate 9 millimoles to her parenteral nutrition. So the 9 millimole that you need to replete, the vial comes in concentration that has potassium 4.4 milliequivalent per milliliter and phosphorus of 3 millimole per milliliter. So first question is, okay, if I need to give her the 9 millimole, how many milliliters of that stock vial that will be? And how many milliequivalents of potassium that will be as well? What do you guys think?
3 mils.
You got a vote for 3 mLs. Okay, another vote for 3 mLs. Okay.
And 13.2 milliequivalent.
Okay, Kingsley, you're a little muffled.
I said 13.2.
3 and what? I see you're typing now. Okay, the answers I'm getting in the chat box are also correct.
I said 3 mLs and 13.2 mLs
Yep.
milliequivalent of potassium.
Milliequivalents. Second one is milliequivalent. Correct. All right. So we said the volume needed to provide the required phosphate equals what? We have 9 millimoles that I need to replete. The concentration is 3 millimole per milliliter. So you do ratio proportion, that ends up being 3 milliliters. So those 3 milliliters have both phos and potassium. So how much? We said that the concentration, the volume is 3 milliliters. The concentration of potassium is 4.4 milliequivalent per milliliter. You cancel the milliliters out, multiply the 3 by the 4.4. That gives you 13.2. Does that make sense?
Mhm.
Okay. All right. The rest of micronutrients, so vitamins, you don't have to know any of these numbers that are on the right side. But basically, vitamins, they come in a pre-made vial, so the ingredients and the ratio between the ingredients are exactly the same for all the products. It's a combination of fat soluble and fat insoluble or water soluble vitamins. So fat soluble are vitamin A, D, E, and K, and water soluble are mainly vitamin B and vitamin C, which is also called ascorbic acid. They are made to mirror our required daily allowances of vitamins. So if you're not receiving it orally or you're not receiving a sufficient amount orally or intrally, that you're getting that through the parenteral nutrition formulation. So again, you don't have to memorize the numbers, but just understand that these are the ingredients there. Vitamin deficiency, I'm not going to go over this because I believe you have a dedicated lecture or part of a lecture on vitamins. So this is more of an FYI that why we care about repleting vitamins because obviously deficiency can result in several morbidities. Trace elements are another element of micronutrients that are added to parenteral nutrition. So these are elements that are generally in our body in very small amounts, but they are still important for cell function in general, mainly enzymatic reactions. So the ones that you're probably more familiar with are your iron, zinc, which iron obviously is important for hemoglobin formation, zinc for wound healing, um, copper, chromium, manganese, all these ones. Those ones are in comparison to the multivitamin, which comes in one standard formulation. These ones come in several different formulations. If you do go out in your appies, you might hear the term MTE3, MTE4, MTE5. MTE is multiple trace elements. So those ones are different formulations just because the evidence keeps going back and forth of, okay, well, we need to cut back on this and we need to increase that and so on. And that's why you see a lot of ranges in that slide. Some like selenium, for example, it says 0 to 60. Some formulations don't have selenium at all, and other have all the way up to 60 micrograms and anywhere in between. Um, when you do have the slides, and happy I remember that, make sure that the correct version of the slides is available on Canvas. Um, Dr. Foles is uploading the version. I think she already uploaded the version of it. If you don't have the slides, please let me know, and I'm happy to share that with you. The when I say correct version, there's like very few things that I took out from the slides of last year. But you know, each version is going to be very almost identical. But the reason I bring that up is because when you look at the slide, if you have downloaded in the footnote, it gives you a little bit of information about the aspirin recommendations for, you know, adjusting the dose of one thing of the trace elements versus another and so on. You don't have to know that information in the footnote. This is more an FYI, but just to understand that there's several different formulations with different combinations. And I think that's the last thing in terms of additions to parenteral nutrition is medications. And this is important for us as pharmacists, obviously, to understand that number one, that there is a possibility that we can add medications to parenteral nutrition, and number two, how that interact with parenteral nutrition, if it does, and what's the benefit that can be given if you add medications to parenteral nutrition. So the good example that you'll see more often is the proton pump inhibitor, and that's one of the things that I just caught recently, is that in the slide it says protein pump inhibitor. There's nothing called protein pump inhibitor. On the slides, it's in the correction. I apologize for the typo. It's proton pump inhibitors and H2 receptor blockers or antagonists. The reason these are commonly included in parenteral nutrition is because when you think of this patient is not eating or drinking or getting any parenteral nutrition, right? Or sorry, or getting any enteral feed or nutrition by non-parenteral resources. They are critically ill. They could be septic. They could be in vasopressors. All these things that could increase the risk of having a peptic ulcer. And one of the ways to combat that is by using proton pump inhibitors or H2RAs. Um, Generally not both, but sometimes you can use both. If you do go on a critical care API, you'll learn a lot about what are the indications of peptic ulcer prophylaxis by pharmacological interventions, but that's beyond the scope of this lecture. Insulin is another additive that can be often used and added to parenteral nutrition formulation because what is the biggest macronutrient that we're adding that provides us with a lot of calories?
Carbs.
Carbs. Yes.
Glucose.
Yeah. So carbohydrates, mainly hydrated dextrose. It doesn't give as much calories per gram as lipids, obviously, but you add a lot more carbs, and they are the primary source of caloric intake in parenteral nutrition or in enteral nutrition for that matter. And that is important to know because you can cause hyperglycemia, which we'll talk about later in the lecture. Hyperglycemia is a complication of parenteral nutrition. So generally, you treat hyperglycemia in an inpatient setting using insulin. You might think, well, it's easiest then that you just give the source of carbs and the antidote of carbs, quote unquote, in the same bag. And that works sometimes, but it has a little bit of nuances on how fast you can clear the carbs from your body versus how fast you can clear the insulin, what kind of insulin goes in. Again, this is a little bit beyond the scope of this lecture, but know that a lot of places do use insulin as an additive inside the parenteral nutrition, while other providers prefer to use it outside the parenteral nutrition formulation. Levocarnitine is another additive that you could use or a medication that you could use. The main use for it is really for hepatic dysfunction, which is another metabolic complications of parenteral nutrition we'll talk about later. You don't need to know more details about it. Just that's what it's used for. Heparin is another thing that a lot of patients, most patients actually who are hospitalized, are going to be receiving some form of VTE prevention. So VTE or venous thromboembolism, which is basically pulmonary embolism and deep venous thrombosis. Because these patients are, like I said, again, critically ill, they're not moving that much, they might have some hypercoagulable conditions, their venous stasis, all these factors that can predispose anyone to have a clot. So you give these patients heparin or a low molecular weight heparin or any anticoagulant. So heparin is an injectable drug. It would make sense that you would put it in the bag as well for that reason. Heparin, just like any drug, has complications as well, and we'll talk about it. Can cause hyperkalemia later on. But just another medication that can be added. But these are the more common ones that you'll see. There are some other medications that can be added, but not often. All right, so we're done with SP. This is just a bonus case just to get you to practice again the math that goes in calculating parenteral nutrition. So we have a patient who, let me see if I can summarize that. Patient basically had some abdominal surgery and came in with nausea and vomiting, has some irrelevant past medical history, takes some medications that are also irrelevant. His weight today is 74 kilograms, height 183 centimeters. Lab workup shows nothing. The patient basically has small bowel obstruction. So as you recall, small bowel obstruction is a contraindication to enteral nutrition. Obviously, he's not going to be able to eat because of the small bowel obstruction and because of the fact that he's coming in nauseated and vomiting. So that's the indication of this guy being on parenteral nutrition. So day one of admission, he tried to drink soda, which resulted in an aspiration episode with significant respiratory compromise. Then the team made him NPO, or not to take anything by mouth. 2 days later, this is the first day you're coming back on the service. The attending physician orders IV fluid running at 83 milliliter per kilogram per hour, which is a typical infusion rate for a patient that weight. Also add IV thiamine, folic acid, and multivitamin. This is something called banana bag. If you've heard of that before, if you haven't heard of it, it's a more or less an outdated practice. It's a 1 liter bag that looks yellow. It's colored yellow because of the addition of multivitamin. That's why it supposedly looks like a banana. That's why they call it banana bag. But generally just IV fluids and additives. The provider also places an order for starting SEWA protocol, which You might have not learned that. Have you learned about alcohol withdrawal yet? No? Okay. Don't worry about that part. And nutritional consult. So the question is asking you, okay, after you read all this long story, calculate the TPN caloric fluid and macronutrient contents. So think back on the first lecture when we were doing the Harris-Benedict equation, fluid amount calculations, and the macronutrients. But this question is not an open-ended question. It's a multiple choice. So it's giving you options. So knowing the patient's information, I want you to look at the options and tell me which one you think is correct. And while I take that phone call, I'll let you guys mull over that problem. Varmt Make a look.
Yeah, correct.
Sorry about that, guys. It's life of an impatient pharmacist. You get questions all the time. Um, all right. Got any takers? I don't see any votes in the chat box.
Before 80, I can't see there.
What was that,
Okay.
Kingsley?
I was trying to calculate the total fluid requirement,
Uh-huh.
and I was trying to apply the formula of 1500 for the first 20 kilograms
Uh-huh.
and the balance at 20 mils per kilogram.
Based on her age, because it's either 20 or 15 based on the patient's age, right? The holiday seeger.
I think I need to check whether, I think it's the age. Let me check that.
Any thoughts from anyone else? I would tell you that the best way to do that is not to take one option and go number by number, because that will take you forever to solve a question like that. The easiest way for me and the way I built the question, because that's usually how these questions are built, is that, okay, if I go for just the first number, the B or the T, that it should actually be TE to be more accurate. If I would look, okay, option 1, 2, 3, and 4, which one is closer to the range would be, and that would actually start eliminating options for you. So if once you narrow it down that way, you keep going horizontally and move on to the volume, and that will narrow it even further. If you work your way through it, you probably will reach the answer by the second number or the third number. No, the option that I got in the private text message is incorrect. Sorry. Okay, let's try this together. So we said the float requirement. Let's try the float requirement. So we said it's either 30 milliliter. Okay, hold on. There's another vote. No. Okay. So 30 milliliter per kilogram per day for a 74 kilogram, it's about 2,200 milliliter per day. If you use the holiday Seeger, so it comes to about 2,580 or 2,600. So we're roughly looking at a float requirement of 2,200 to 2,600 per day. So if I go back to the options, so if I'm looking for a volume of 22 to 26, then I know that this option number one is incorrect, right? And I know this one is incorrect as well. This is lower, but it's not that much lower. So, sure, this is at the lower end of it. So now I know right off the bat, I eliminated option one and option four, and I'm between two and three. So going back to the energy requirement, I mean, could have gone either way, but for the sake of consistency, this should have been listed first. But 25 to 30 kcal per kilogram per day for 74 kilogram person, that's 1850 to 2220. If you use the Harris-Benedict equation, that would be this number. So I know for the TEE, or actually no, that is BEE because I didn't give you a stress factor here. Anywhere that number should be anywhere between 1800 to 2300, right? So if I go back to the slide before, we narrowed it between number two and number three. I'm looking here, okay, 1920, 2235. So these two are still valid options. Okay. So now I'm left with, okay, if the BE is the same, or acceptable, the volume of fluid is acceptable. Now we're looking at vast differences between the dextrose, the protein, the lipids are about the same. So let's go and calculate the dextrose. So we said the amount of dextrose, if I use the first one, the option C, which is 300. If I use 520, if we're going in order, 520, we said 520 is going to be multiplied by 3.4, which is going to give you some number. I can't do that math on top of my head. But if you go through it this way, okay, 520 multiplied by 3.4, then the amount of protein, which was 80 something, multiplied by 4 as well. Then the amount of injectable lipid emulsion, and that will give you the same amount. If you add them all together, that number for option B is not going to give you the same exact number of BEE. Is that confusing? So let's do option C. Maybe that will clear it up a little because that's the right answer. So we said that this is within range. The volume is also within range. Let's try the dextrose 300 grams. 300 grams, we said for dextrose or hydrated dextrose, it's 3.4 kcal per gram. So for 300 grams, that gives you about 1,000 calories. For protein, it's about 100. Everyone has a 4, so it's 400. For injectable lipid emulsion, for a total volume of 250, that gives you 500 because you remember that we said the 20% is 2 kcal per milliliter, the 30% is 3 kcal per milliliter. So this is the 20%, so 250, that gives you 500. So if you add this, and that gives you 1920, which is the exact same number that it says here. Does that make sense? Okay. This is a very hard question. I will never, ever give you a question like that on the exam. This is more of a practice, critical thinking, exam taking skills, just to get you a little bit more practice. But I will never have a question that difficult or even nearly close to that in the exam.
Sorry. So going back to the calculation, the
Yes, sir.
500, did you multiply 250 by 2? Is that how you got the 500, or how did you get the 500 there?
Which 500 are we talking about?
Like the bottom here, you say 250 ml, then we'll provide 500. How did you get the 500?
Okay, so let me go back to the slide where we actually talked about this. Try not to look at the slide now because I'm going to go through it very quickly. I don't want to induce seizure in anyone. Oh, there we go. All right, so here in the second bullet, it says injectable lipid emulsions are available as 20% and 30%. They do provide the 20%, it gives 2 kcal per milliliter, and the 30% gives 3 kcal per milliliter. Okay, so if you go back to the problem, so we said that she is using 250 mLs of the 20%. So for every 1 ml, there are 2 kcal. So 2 multiplied by 250 is 500.
Gotcha. Thanks.
No problem. Other questions? All right. Okay, monitoring. A lot of information here. What I want.
Dr. E,
Yes, ma'am.
I'm so sorry. Can you go back to the slide one more time? I was trying to get a
Of course.
picture. Thank you.
Yeah. And so this is the last lecture of the 3 series, and or Dr. Foles, I should say. Dr. Foles will share the slides with the answers with you guys after the lecture, and we'll share the recording with you as well. So you don't have to worry about like writing the numbers as much as making sure you're understanding all the gibberish that I'm throwing
Thank
at.
you.
You're welcome. All right. Other questions? All right. So monitoring. Very important thing to do as a pharmacist while you have a patient who is on parenteral nutrition is that you monitor several things to make sure that you are providing efficacy while you're maintaining safety, just like monitoring for any medication. And that's an important thing when you go in your APIs and you give your SOAP note or your presentation to your preceptor, like, oh, I'm going to monitor for this medication efficacy by XYZ and safety by XYZ. They will be very impressed. So just keep that in mind when you're assessing your therapeutic options. So similarly here in parenteral nutrition, there are several things that we're going to look at to make sure that we are doing exactly what we're set out to do by giving the patient parenteral nutrition. First thing we're going to look at is capillary glucose or blood glucose in general, which should make sense because we're giving the patient a lot of carbohydrates. You want to make sure that you are giving them just enough, not too much to induce hyperglycemia, and not too little to induce hypoglycemia, which both can happen. So the frequency of monitoring at initiation of therapy and long-term therapy, I don't want you to know all that information. That's too much to know at this point, but just understand, okay, yeah, we monitor blood glucose to prevent complications. BMP, phosphorus, magnesium, calcium, all these things because we are providing these electrolytes. And it gives us an idea of the patient's serum levels of these electrolytes as well as the hydration status, the tonicity and osmolality, all these things that we make sure that we are providing just sufficient amounts. CBC, that could be mainly an indicator of if you do have leukocytosis, that's an indication of inducing an infection or inflammation in general. If you are giving too much fluids, you're going to see these numbers decrease. So you'll see the patient's white blood cell count is reduced, their red blood cell count is reduced, the platelets are reduced because you're diluting everything. So that's why we order CBC. Liver function tests and liver enzymes, these are because parenteral nutrition can cause hepatotoxicity. So you want to make sure that you are not inducing that. So you monitor it regularly. Similarly, serum triglycerides because it can be hepatobiliary toxicity. And other things such as iron, vitamin D, trace elements, these things, because you do provide it through the formulation. So make sure that you are not inducing any anemia or vitamin deficiency or so on. Weight that we monitor typically daily to make sure that the patient is not accumulating enough fluid or losing weight as a result of providing subpar amount of nutrition. And lastly, total fluid intakes and output. So the I's and O's that we talked about the last lecture or the one before, again, was the same thing. It's not all calories, it's also fluids to make sure that we're providing just the patient's fluid needs. Now, with that in mind that we're monitoring every single patient on parenteral nutrition, there are some patient populations that will require even closer monitoring. And this is an important thing to understand because your role as a pharmacist, you're not the main one driving nutrition, but you have a big role in it. So you are um, keeping a close eye on these things in those specific patients to make sure that they don't develop any complications. So diabetic patients, as I said 3 or 4 times already now, that patient can be at risk of hypoglycemia or hyperglycemia. So if you have a diabetic patient already, they can most likely they will be at the risk of hyperglycemia when you give them a lot of carbohydrates, or you're adding an additional insulin in the back that can induce hypoglycemia. Pulmonary disease, because in most pulmonary diseases that you have restriction into the amount of gas exchange, whether it's because of obstruction or fibrous formation or so on. And in that case, you are accumulating more carbon dioxide. So if I give you carbohydrate in the parenteral nutrition, one of the end metabolic byproducts of carbohydrate is carbon dioxide. So your naturally produced carbon dioxide already accumulating in your body, and then I give you an additional source of it that can cause pulmonary complications. CHF is another patient population you need to keep a close eye on, because fluid accumulation, if you're giving too much fluid, can cause exacerbation of CHF symptoms. So by just providing a lot of fluids, you can cause the patient to have significant morbidity and mortality. Severe malnutrition, the reason that this is a patient population you need to closely monitor is because of the risk of refeeding syndrome, and we'll talk about that later. Hyperemesis gravidarum, this is a condition that happens in pregnant patients, that you do have excessive amount of vomiting. So when you vomit, you're not able to take and absorb a lot of nutrients, and also a lot of fluid loss, a lot of acid-base abnormalities. So when you start giving them sufficient nutrition after a long period of starvation, that can cause, again, refeeding syndrome. The right side of the screen has a lot of electrolyte abnormalities that you can imagine. They can be low or high based on how much you are providing. So it makes sense if you are having these problems at baseline, then you're at risk of having worse problems after receiving parenteral nutrition. All right, so we'll jump first into refeeding syndrome, but I want to pause for a second, see if you guys have any questions, comments, concerns, digesting the information so far, digesting your lunch. It's okay, I'm joking. Okay, refeeding syndrome. So refeeding syndrome is one of the most common complications you'll see with parenteral nutrition. And I use an analogy that hasn't gotten me in trouble yet, but probably will one day. So just to understand, because this was a very confusing concept for me to grasp as a student. So going with this line, the analogy is basically, I imagine myself when I was a student, I wasn't making a lot of money because I worked a part-time job, made little money. I used my credit card quite often, right? So I was in a little bit of debt based on that credit card. Not a lot of income, have some student loans, so on. So that's your body while you're in starvation status. Then I graduated pharmacy school. Let's say graduated residency, because when I did residency, I wasn't making a lot of money either. When I graduated residency and I got my first job and I made 6 figures. So now I'm like, this is amazing. What am I going to do? I'm going to go shopping. I'm not going to make payment for the credit cards. I'm not going to make payment for the student loans. I'm going to go shopping. Then I ended up with more debt. I mean, this is not what really happened. I don't want you to judge me. This is not what happened, but just to go with the analogy. So I ended up with more credit card debt than I started with, but that makes no sense. I'm making more money now. How do I have more credit card debt? This is exactly what your body does. That you're going through starvation, and your body, when you're not receiving enough nutrition, your body is adjusting slowly and slowly and slowly to starvation, trying to limit all its caloric resources and fluid resources to the most basic functions to keep you alive, right? Then all of a sudden you get admitted, and some generous pharmacist and dietitian gives you every single calorie you need and all the amount of fluid that you need, every single thing that you need. Then your body's going to have a fiesta. And you're like, oh, I've been putting this on hold. I haven't been building muscle. I haven't been storing glycogen. I haven't been, regenerating my cells and all this stuff. So it's pulling all these resources that's available to it in a significant amount, to the point that it's depleting it. if that makes sense. So it's a condition when you have the sudden introduction of sufficient nutrition after a long period of starvation that results in significant electrolyte abnormalities, fluid abnormalities, and vitamin abnormalities. These are all going to be down. So you're going to have hypokalemia, hypocalcemia, hypomagnesemia. These are the main electrolytes that you see that drop. Okay, so that's basically what refeeding syndrome is. Does that make sense? Questions?
I have a question.
Yes, ma'am.
So, what you explain is like the body receive a lot of nutrient, these all proteins, and it's like have too much, and then going down because that. I don't know if I explained well.
You did. I mean, and you understood what I was saying exactly.
Yes. Okay.
Yeah. I mean, that's basically again going back to the analogy. I had, let's say, just keeping the same analogy. Like, let's say I had $10,000 in credit card debt, right, at graduation, and $1 million debt in student loans at graduation. Then after 1 year, let's say out of pharmacy school, because I'm not making any payments on student loans, now that $1 million, now $2 million, and that 10,000 credit card debt is $100,000 credit card. How, when I'm making more money, is because I'm going to use all the resources that are available to you, that six-digit figure in income, and I'm going to create to buy a whole lot of things that I've been holding myself or stopping myself from buying while I was in pharmacy school. So your body is doing the same thing. It's been breaking down muscle to provide energy while it was starving. So now it's going to build a lot of muscles. How is it going to do that? It's going to need ATP. How is it going to make ATP? It will steal phosphorus from the parenteral nutrition that you are giving. Right? That's what the P in the ATP is, phosphorus. Then you end up with less phos. Same thing with calcium. Again, you were using it for muscle. I use muscle as the main organ or the main tissue that gets emaciated during starvation. You're using a lot of calcium during in your, if you remember, sarcoplasmic reticulum. This is more details than you need to know. In the muscle that you were not using all that much during starvation, now you have a lot of calcium that goes into your muscles that you are building, and you're probably regenerating the tissue and all that stuff. And now you end up with hypocalcemia that can cause cardiotoxicity. So that's basically what happens in that process, is that your body is overusing all the available parenteral nutrition resources and micronutrients and macronutrients, and end up using more than it actually needs. And you can imagine that patients who are at risk of those are the ones that have been starving for a longer period of time, right? So when we said in the first lecture who qualifies for receiving or who qualifies as being malnourished is about 1 to 2 weeks. So the longer you're out, longer than 2 weeks, that you haven't been getting enough nutrition or any nutrition, that your risk of having refeeding syndrome is going to be higher. If the patient has cancer, because it's a hypermetabolic condition, so your body's already breaking down cells at a faster rate, using all the resources at a much expedited rate than it usually does, then that's going to predispose the patient to having more refeeding syndrome. Short bowel syndrome and inflammatory bowel disease, these patients, and same thing with low birth weight, these patients don't absorb a lot of nutrients. So they're at baseline, they are malnourished. So again, higher risk of refeeding syndrome. High output fistula, diarrhea, vomiting, these patients are not absorbing enough nutrients, same thing, that are going to have high risk. So generally, because like I said, it's a common condition, that it's not like some random fancy thing that you read in a textbook. It actually happens in real life quite often. What we try to do to prevent it is the main thing, is to just do prevention, because there's no treatment for refeeding syndrome. Once it happens, it happens. But you try to prevent it by not providing the full nutritional needs at the beginning. You start slow, and you start low and go slow, basically. You give about half or so of the nutritional needs, and you start building up a little bit. Mainly in the carbohydrate amount, that you try to give them about half, and you increase it gradually as the patient tolerates it. And you monitor closely to make sure that the electrolytes and the fluids are not deficient. And if that's the case, then you just replete it. I mean, that's what you're going to have to do, right? questions about refeeding syndrome? Okay. Next is catheter-related bloodstream infections. So you recall when we were talking about access of parenteral nutrition, we said that based on osmolality, you can use a peripheral parenteral nutrition or a central parenteral nutrition. Peripheral is usually in the distal line versus central that goes into the in a vein that's closer to the heart, bigger volume, bigger fluid flow of blood. You can put as much osmolality as you can. The problem with these things is that you are providing access, direct access to your bloodstream to the outside. So our skin that we don't think so much of, and you have learned about ID yet, or you haven't studied ID pharmacotherapy yet?
Yes.
Yes. Okay. So you've learned one in the SSTI lecture as the skin serves as a barrier against bacteria, that we have a lot of bacteria on our body, especially gram-positives. They don't go inside because our intact skin. And once that barrier breaks, now you have risk of infections. Same thing here. You're bypassing that barrier by inserting an IV line. So that can introduce mostly bacteria, but can also be fungus or even virus. But usually what we see with TPN is bacteria and fungus. And generally, the catheter-related bloodstream infection is that you see at least one of two. Usually when you're getting blood cultures, you get a set of two, one aerobic and one anaerobic, and you need to at least to diagnose that condition, you need to at least to have one of the two or both of the cultures to be positive for a bacteria or a virus. And there would be no explanation for where that infection coming from other than the catheter. Your patient, just like an infection, is going to be febrile. It's probably going to have tachycardia, maybe tachypnea if there is a suspicion also of pneumonia, but mostly it's just a tachycardia, and the white blood cell count is going to be high to fight that infection. And when you look at the insertion site of the catheter, is going to be red, inflamed, swollen, maybe there's some discharge and so on. Causative bacteria, as I alluded to, things that live on the outside of our body. So the coagulase negative staph, these are like staph epidermidis, staph saprophyticus, those normally live in hygienic patients even. They live on our body because we're not sterile. But MRSA can also live in our body, and these, when they gain access inside, they can develop bacteremia and even endocarditis. So how do we treat that condition? Well, the source is the catheter. Well, remove the catheter. I mean, sometimes it's not clinically feasible, but most of the time you're able to pull the catheter and just stick another line somewhere else to continue to provide nutrition. And obviously use systemic antibiotics that will be targeted to the bacteria that's grown or the fungus that's grown, and the sensitivity testing for that microorganism. Next complication is hepatobiliary complications. So hepatobiliary, so hepato's first part is the liver, biliary, it's the biliary tract, and that involves the biliary secretion in the liver, and also the bile tract and the gallbladder. And there are several ways actually that the parenteral nutrition can cause damage to these organs or this set of functioning tissue. One is steatosis, which is basically fat deposition in the liver, and that usually happens when you are providing too much food, just like it happens to any of us, right? If I eat too much, I'm going to deposit fat, not just in my liver, but everywhere else. And usually you see steatosis, but you see aminotransferase, so AST and ALT are going to be elevated gradually, and that's the problem. Then what you do is that you cut down on the parenteral nutrition feeding, especially the lipids. Cholestasis is another possibility that parenteral nutrition can cause hepatobiliary damage by. And cholestasis, chole means bile, stasis, static, it's not moving. So you have the bile that's not moving and sitting inside the liver. And usually that irritates the liver, and you start seeing alkaline phosphatase and bilirubin go up. So that's another way. The third way is that gallbladder itself is that the bile is static inside. If you do remember from the first lecture when we were talking about the importance of oral or enteral feeding, is that when I explained to you that when you eat a fatty food, there is a hormone called cholecystokinin that causes the gallbladder to contract, right? So if you're not feeding the patient orally or enterally, that is not happening. The gallbladder is not contracting. It's just sitting there, relaxed, accumulating bile in there. That bile is thick and it can start making stones. So a patient would develop cholecystitis eventually. And you start seeing also alkaline phosphatase, AST, ALT elevation. Sadly, that ends up being a surgical complication. But if you're monitoring closely, that it doesn't develop into that severe of a condition. But you can see there are several ways that parenteral nutrition can actually cause damage to both the liver and the biliary system. So what we try to do is first, this is one of the fun situations when if you're rounding with a multidisciplinary team, people start pointing at each other like, it's the medications. No, it's the parenteral nutrition formulation. No, it's the enteral nutrition formulation that we're providing on top of the parenteral nutrition. Oh no, the patient is having shock alert. So like every discipline is trying to blame the other for why the liver is shutting down. So first, your job as a pharmacist is to make sure that, okay, do I have any active medications that are hepatotoxic? And if the answer is yes, can we get rid of them, or can we switch them to something that's not hepatotoxic? Okay. Other conditions that are not medication related obviously can be something like sepsis, viral inflammation, or infection like hepatitis, and so on. Usually, you get an ultrasound and you try to figure out what's going on. But that's the first thing, is the exclusion. Then there's some other techniques that can actually help with that. So if you recall, when we were talking about parenteral nutrition, we said it's typically a continuous infusion over 24 hours, but sometimes we cycle it over 18, 16 hours, 12 hours even. That limits the amount. I mean, you're still infusing the total amount that you were going to do over 24 hours. You're still going to do it over a short period of time, so that you're not cutting nutrition from the patient. But that still gives the patient some off time, that there's no exposure. So the liver kind of rests a little during that off time. And so that helps, is one of the techniques that you can actually do to decrease that exposure. Decreasing the lipid amount, as I said, especially with steatosis, decreasing lipid amount obviously is going to help more with reducing that inflammatory response from the liver. Decreasing the dextrose as well, because there's a lot of calories. If you're providing too much, you're storing glycogen mainly in the liver. So you want to make sure that you decrease that as well. You try to maximize enteral intake. So the fact that a patient is on parenteral nutrition doesn't mean that they're not taking anything enterally at all. That's sometimes the case, but it's not always the case. But the question you should be asking yourself, well, if they're able to take enteral nutrition, why are they taking parenteral, right? The reason usually that happens is that the patient can take enteral nutrition, but not enough. Like they can take sips of water, they can drink like a protein supplement, but not enough to provide them with their all caloric needs. So usually what we do is that, yes, we still want to stimulate the gut. We still want to use it and push as much as possible towards giving them all their caloric needs through enteral nutrition. But at the meantime, we're providing them the most of it through parenteral nutrition. So if you can do both, fantastic. If you can't, then, you just have to maintain just parenteral nutrition. But if it's a possibility, then you maximize your enteral nutrition. And lastly, Ursodiol, which is a medication that does help with biliary movement or the flow of bile. You don't have to know much about it. It had limited data that it's possibly beneficial in hepatobiliary damage, or the name that's most commonly used in literature is parenteral nutrition associated liver damage, or PNLD. So also that has some benefit in it, but it's not high level evidence. So you don't have to know much about it. Okay, we're gonna let that ring for a little. Let's keep going with complications. So we have hyperglycemia and hypoglycemia. So we talked about this already several times, about the, either providing too much carbs or too little carbs. If you provide too much carbs, you can induce hyperglycemia. That's the main mechanism, but there can be also so many other things, such as you have insulin resistance, right? These patients, especially in diabetic patients, they might have insulin resistance. There might be increased gluconeogenesis. What that means is that gluconeogenesis is a mechanism of your body to form or make glucose from other non-carbohydrate resources. Or you could have increased glycogenolysis. So glycogenolysis is the opposite, or kind of, is basically you're still making glucose, but from glycogen molecules that you're storing in your liver and your muscles. So both processes end up in production of glucose. So if you have increase in either one of them, if you have insulin resistance, or if you're giving too much glucose, all these things can cause hyperglycemia. Why is hyperglycemia bad? Well, I mean, we said carbohydrates are a source of calories, right? So more energy. Why is that bad? Well, it causes a lot of problems. That's why diabetes is a bad thing. But most of the complications of diabetes happen with long-term hyperglycemia, right? Like well, you haven't learned about it yet, but there's like microvascular that increase risk of heart attacks and strokes and renal failure, all this stuff that happens from long term. But on the short term, if you are inducing hyperglycemia in generally non-diabetic patient, that decreases wound healing, which is a problem in an acutely ill patient, right? You can induce diabetic complications such as DKA or HHS. You can even induce coma or even death. So as you can imagine, serious things. That's why we are talking about it. Guideline recommendations varied a little about what our goal blood glucose should be. So Aspen or American Society of Parenteral and Enteral Nutrition said it should be 140 to 180 versus Society of Critical Care Medicine said it's 140 to 150 all the way to 180. Potato, it's the same thing basically. And that's usually the goal blood glucose for any inpatient management. So how do you manage that? Do not advance the glucose or the dextrose content until the patient is tolerating. And similar to when we were talking about refeeding syndrome, and you start low and go slow. So we're going to give the patient a little bit, and the patient is not hyperglycemic. I'm going to increase that the next day. And the patient's still not hyperglycemic. I'm going to increase it slowly towards the goal. Okay. Hypoglycemia on the other end causes different problems. This is a more serious condition if it happens in acute setting because when you're hypoglycemic, you can fall, you can hit your head. Hypoglycemia can even cause coma and death. So another serious problem. And that usually happens, I guarantee you, if you do practice in an inpatient setting, one day you're going to get a phone call, like the phone calls that I'm getting from a nurse frantic saying, oh, my patient is hooked up to his or her parenteral nutrition. They're going to the MRI. Obviously, you can push the patient in the MRI machine with the parenteral nutrition or any fluid there. And I'm going to need to discontinue. What am I going to do? That is an appropriate frantic response. It doesn't have to be that dramatic, but you worry about it because you're providing a patient with a lot of nutrition. And to just disconnect the line is going to cause your patient's serum glucose to drop suddenly. And that's a problem, causing hypoglycemia. Management usually is that you do one of two things. You either ask the nurse to run the bag at half the rate, so you're kind of tapering the glucose intake, or instead of that, you just run a dextrose bag. If you can't do the parenteral nutrition at half rate, you just run some bag that has dextrose in it. So you're providing that glucose intake to some extent for 1 hour, and then you discontinue. Questions? All right, continuing with the metabolic complications, you can see there's a lot of them that go with parenteral nutrition. So metabolic bone disease, that mainly includes osteoporosis, where there is bone resorption. So if you recall, there is bone absorption or resorption, and now I'm blanking out on the other name. It's not absorption. Bone formation and bone destruction, basically. Bone resorption is bone destruction. That happens because our bone is a vibrant tissue. It forms by calcium and phosphorus mainly, and it regenerates itself and so on, just like most of our tissues. So in a period when you have calcium and phosphorus deficiency, your body turns to the bone. That's a big structure in our body. And it's like, hey, can you lend us a little bit of calcium and phos? So generally that happens when you have hypoglycemia, when you have hypophosphatemia, hypomagnesemia as well. Vitamin D deficiency, because vitamin D is responsible for calcium and phosphorus reabsorption from the urine and the stool, or I should say from the kidney and from the GI tract. So if you're deficient of vitamin D, you're deficient of these elements. Also keep in mind that these patients are going to be acutely ill. They're in hospital bed. They're not getting sun exposure. That's the primary source of vitamin D. So that also, exacerbates things. And the last possible cause is aluminum-containing parenteral nutrition. This is more of an outdated thing. Now, a lot of parenteral nutrition formulations now have aluminum, but aluminum does cause bone resorption. So generally, when you are closely monitoring a patient's electrolytes and you start noticing that calcium, magnesium, phosphorus are dropping, the first thing that you're going to do is you're going to replete those, right? If you can replete them orally, fantastic. Like I said, again, is the fact that your patient is receiving parenteral nutrition doesn't mean that they're not able to take things by mouth or in a feeding tube. So if you can, fantastic. If you can't, then you're going to give it IV. You try to also avoid excessive protein because excessive protein intake can induce bone resorption by, at least to me, an unknown mechanism. So keep that in mind. Again, adding calcium, adding phosphorus, maintaining magnesium and copper intake, minimizing aluminum, as we said, that can be a predisposing factor, and avoid adding heparin. Heparin can cause bone resorption. When we think of heparin or anticoagulants in general, we think the complication is bleeding, which is true. But it can cause a little bit of electrolyte abnormalities, such as hyperkalemia to some extent. It can also cause bone resorption, long-term use, but you would try to avoid adding the heparin inside the bag. Then oral pharmacotherapy, like we said, electrolyte repletion through the mouth, or also you can add bisphosphonates. Bisphosphonate, you've learned about bisphosphonates yet?
In our top 200, I think.
Okay. Yeah, so alendronate, risedronate, pamidronate, right? All those ones that help prevent osteoporosis by depositing calcium and phosphorus in the bone. So you're providing sort of the parenteral nutrition and giving a drug to help deposit it in the bone. All right, I think that's the last slide of complication, which is just a bunch of miscellaneous small ones. So extravasation is a complication that happens also quite often with parenteral nutrition, especially if it's peripheral parenteral nutrition. So remember, we said that we're limited by osmolarity of 900 milliosmol. So that's still a little bit high. So if you do have any, because of line dislodgement or, whatever happens, the patient moves, the patient pulls their line, which happens all the time, that highly osmolar, highly concentrated fluid is going to start dissipating into the surrounding tissues, causing significant tissue destruction. So usually you use hyaluronic acid or hyaluronidase, and you just infiltrate it around that area of extravasation. That usually helps ease the connective tissue binding around the tissue and help decrease the inflammation and the response. Essential fatty acid deficiency, which could happen if you recall when we're talking about soybean oil-based formulations, that those can be hepatotoxic, so we try to avoid them by using non-soybean oil-based. If you use non-soybean oil-based, you're not providing enough fatty acids, so you cause fatty acid deficiency. Forgive me, guys, just give me 1 second. Sorry about the interruption, guys. All right, so we're talking about essential fatty acid deficiency that could happen if you use non-soybean oil-based formulations, and because they don't have enough fatty acid, that can cause essential fatty acid deficiency, which can cause anemias and neutropenia and thrombocytopenia and skin malformations. So somewhat serious condition. Immunosuppression can happen when we use soybean oil-based formulation. So whether you use soybean oil-based or non-soybean oil-based, there is a little bit of a complication here or there. But what I want you to know is just what's on the slide, so you don't have to know more details beyond that. Hypertriglyceridemia, which can happen when you have excessive triglyceride or injectable lipid emulsion in general that you are providing through the parenteral nutrition formulation. The problem was specifically excessive triglyceride that stimulates the pancreas to release lipases. So if you give too much, you stimulate the pancreas too much, that can lead to acute pancreatitis. So what you need to do is you just decrease the amount to minimize the exposure, or in case the serum triglycerides are too high, meaning greater than 400, then you stop giving lipids altogether. So the parenteral nutrition bag is going to have macronutrients of carbohydrates and protein, no lipids. Next is azotemia, or increase in the nitrogen. So nitrogen, if you recall, that's the metabolic end product of protein. So if you give extra protein, that can induce azotemia. It can also happen when you learn about BUN over serum creatinine and renal module next semester. But dehydration in general can cause azotemia as well. So generally what you try to do is you reduce the protein intake to avoid any, I mean, obviously with the dehydration, you're going to provide them with more fluid in the parenteral nutrition, but generally is that reduction of protein to decrease the amount of nitrogen produced. Blood urine nitrogen actually, or uremia when it happens, can cause significant complications such as pericarditis, encephalitis, bleeding. So an important thing also to keep an eye on. Again, you're only responsible for the information on the slide. I'm just giving you more background information. Vitamin abnormalities, such as the ones that we talked about, vitamin A, vitamin D, E, K, all the fat-soluble vitamins and water-soluble vitamins. Mainly the one that we see is the thiamine, and that's a main ingredient in the multivitamin component, but sometimes the patient need more than that, especially in refeeding syndrome, so you can add thiamine. And lastly, the thing that we don't think of too often because we're thinking as clinicians, but cost. You saw how much complications we talked about. These to address these complications and give therapeutic interventions and prolong the hospital stay, all these things incur cost. The bag itself is not cheap to make the parenteral nutrition, the IV line placement and the IV line maintenance and making sure that the line doesn't get infected and ordering the regular labs daily or weekly. All these things cause a lot of cost. So keep that in mind when you're assessing a patient for parenteral nutrition versus if possibly giving enteral nutrition. Parenteral nutrition is more of a last ditch effort. It's not a fancy thing that, oh, I like to practice. No, it can cause significant harm to the patient. So we try to stay away from it as much as possible. All right, let's take a break here and come back at 3:10. Does that sound good?
Yes.
Yeah.
All right, guys, let's come back. We're almost done with the slides. All right, so there is the bonus case that you see in front of you, and another bonus case because you didn't get enough cases already. I want you guys to work on it independently. I don't have the answers on the slides. I do have the answer somewhere else, obviously. So if you do have problems or if you want to double check your answers, please let me know. Send me an email. I'm happy to meet with you individually or as a group. And as a reminder, when we started the lecture, I asked you to think after we are done with the 3 lecture series to see if you do want to have some form of a recitation or a meeting afterwards or so on, and we can work on scheduling that. All right, so the last, I think 4 slides or 5 slides talk about one last topic to cover today, which is important obviously for our practice as pharmacists, is a drug-nutrient interaction, what that means and how to manage that interaction if it does happen. So as the name implies, drug-nutrient interaction, it's an interaction between the drug and the nutrient in a way where the drug can affect the availability of the nutrient to our body, or the nutrient can affect the drug's availability to our body. And that usually happens in one of 3 ways. As you see in the classification, the second big bullet point is that it can happen in the tube. The tube could be a feeding tube or it could be an IV line tube. So it's tube related, where you have the 2 ingredients, the drug and the nutrient, in the same exact place. Sorry, that's the physical definition of physical. Tube is related as in the drug or the nutrient, or both are interacting with the tube where they are infusing. Physical is that they're both are interacting because they're both in the same exact physical space. And lastly, PK and PKD, or pharmacokinetic and pharmacodynamic, is when one of them affects, or mostly it's going to be the nutrient affects the pharmacokinetic of the drug or the pharmacodynamic of the drug. You guys remember what PK and PD mean? What these two, how these two are different from each other?
I think PK is what the body does to the drug, and PD what the drug does to the body.
Yep, you got it. Yeah, PK is absorption, distribution, metabolism, excretion, right? So what the body does to the drug, you know, absorbs it, distributes it in different tissues, metabolize it and excretes it, renally, GI, perspiration, whatever the mode is. And pharmacodynamic is how the drug affects the body itself by doing therapeutic effect and by doing toxic effects in some instances. So let's start with the first two, the tube related and physical, which two are somewhat related. Is basically we're talking about the same physical environment, whether the drug, the nutrient, or both are interacting with the tube itself or with each other. And these are complications of both enteral nutrition and parenteral nutrition. So in the left column where it says enteral nutrition, this is mostly when the tube feed gets clogged up. This happens all the time, especially if you're putting drugs as well, and especially if we're talking about J-axis J tube or jejunostomy tube or even duodenostomy tube, because they're much narrower caliber versus gastrostomy is a little bit bigger. So usually what we try to do is the water flush. You flush that blockade of drug or of nutrient or a combo. You flush it with water. And you might recall from last lecture when we were talking about administration of medications through feeding tubes or administration of enteral nutrition through a feeding tube is that there is an importance of giving water flushes for two reasons. Number one is because enteral nutrition formulations don't provide enough water amount, so you want to make sure you hydrate your patient by giving water flushes. But the second reason is because water flushes keep the content moving and keeps the tube open. So water flushes are going to be more or less preventive, and you can still try to push it harshly a little bit if there's a clog. There's something also called clog zapper, which is basically a combo of digestive enzymes. So it has like lipase, protease, amylase. These are combined in just one ingredient. It's not really a medication, but you inject it into the feeding tube and it eats through the whatever is clogging up the tube. So these are things that you can do if you have a clog up in your enteral nutrition formulation. If you have an parenteral nutrition formulation, this is mostly the calcium phosphorus that we were talking about, how calcium is +2 cation and phosphorus is a -3 anion, and they both love each other. So they bond to each other so much and they make a lot of small microprecipitates that can end up clogging up the IV line. And this is more of a serious condition because we're talking about an IV line. So usually what I try to do is use a thrombolytic agent. So like alteplase, tenecteplase, retiplase, those ones that we give to patients who have like pulmonary embolisms. You're at that serious of a situation that you are giving it to a patient IV line that's being clogged up. Even worse, you can use hydrochloric acid, which is a highly caustic formulation, but use a 0.1 normal concentration, and that basically cleans everything that's clogging up the line. So those are the management strategies for parenteral nutrition specifically. For both in general, enteral and parenteral nutrition, general concepts that you can do once you have blockade of your feeding tube or of your IV line is that you try to use a different administration route or a device, right? If you have a gastrostomy tube that clogged up, but you still have a jejunostomy axis, you can use that. You know, it's distal to the, more proximal to the obstruction. And if you have an IV line that's dedicated to parenteral nutrition that got clogged up, but you still need to provide IV medications and IV parenteral nutrition, use a different IV line, right? Cycling could be another mechanism that you could do, which we talked about in parenteral nutrition and also in enteral nutrition. If you recall that we used boluses and intermittent feeding and so on, so that's some form of cycling. And the reason that helps is that if you cycle the enteral and parenteral nutrition over a shorter period of the day, then you have that off period when there's nothing infusing, and you can give medication that time. So not right now, physically, these two are not being exposed to each other in the same place. And lastly, if you have to still give nutrition and you still have to give drugs, which mostly is what's the case, is that you try to give alternative drugs from the same class or from a different class that produce the same therapeutic effect, but they are more compatible. Does that make sense? So the slide here is talking about physical and tube-related interactions between the diet and the medication, whether that happens in an EN situation or PN situation. There are some strategies that are specific to each route, but the bottom row is the things that you can do for both enteral nutrition and parenteral nutrition. Okay. Now let's talk about PK and PD interactions between drugs and nutrients, how the nutrient can actually cause an effect to how the drugs are absorbed, distributed, metabolized, excreted, or how the drugs work on the body. And these are the more common drugs that you will likely see in an inpatient setting. Then there's a whole lot more, but they're not used all that commonly. So phenytoin, for example, is an anti-epileptic drug that is highly protein bound. So if you have a patient on an enteral nutrition and you're infusing an enteral nutrition formulation that has protein in it, and you're giving phenytoin around the same time, these are getting mixed up, and the phenytoin is going to bind to the protein in the enteral nutrition formulation, then your body's not going to absorb as much of it. Then you end up with subtherapeutic concentrations of phenytoin, which for an anti-seizure medication, that patient is at high risk of developing seizures. As you can see, this is a very serious condition, so it's important to know that number one, this actually happens, and number two, how to avoid it. And as you can imagine, the easiest solution would be, okay, well, we don't have to put them all in the same place. Usually we're going to have only one feeding tube, so it's not like I can give the enteral nutrition in one feeding tube and the drug in another feeding tube. So what we try to do is the cycling approach again. So you're going to hold the tube feeds for about an hour to 2 hours. There's nothing infusing. You give the drug, then another 1 to 2 hours of hold, then you start or resume the tube feeds. That way they're not in the same place. By the time the drug went into the GI, there's no protein that's lingering. Your body's going to absorb as much of the drug as possible. And by the time that absorption has happened, now you're resuming feeding tube. Okay. Phenytoin is a narrow therapeutic index drug, so you still want to monitor the therapeutic concentration or the serum concentration to make sure it's not dropping. And if all fails, you're going to switch to the the equivalent IV formulation, which would be the phosphonitoin, or even phenytoin is available IV. Fluoroquinolones and tetracyclines you might see more often than phenytoin, and those ones, whether we're talking about enteral nutrition, parenteral nutrition, normal feeding, you should know that you need to counsel your patient on avoiding to take these medications close to cations. So you tell your patient, hey, don't take it with anything that has calcium or magnesium or aluminum or iron or zinc. These things are all cations that if you take it too close to a fluoroquinolone or a tetracycline, they can chelate and bind to each other, and your body is not going to absorb as much of the drug. So the main thing that we see in real life is that, patient takes a fluoroquinolone in the morning with their breakfast, which they eat cereal and milk. So milk has a lot of calcium, or they eat yogurt, or they take their multivitamin and has extra iron in it or something like that. So that goes for when they're taking these medications by mouth, or even if they're taking it enterally. So what you try to do is the same strategy. You're going to hold the enteral nutrition for a certain period of time, depending on which fluoroquinolone you're talking about, because it's not the same number of hours. You give the fluoroquinolone or the tetracycline, and then you continue holding for a certain number of hours, then you resume the feeding tube. Okay, is that making sense? Okay. So that's your first strategy. You try to avoid giving specifically ciprofloxacin. Ciprofloxacin is available actually as a liquid, and that liquid formulation is lipid-based, which makes it bind significantly to the feeding tube. So it's not even the interaction with the enteral nutrition, is with the feeding tube. So we try to avoid using that specific formulation in a feeding tube in general. And lastly, you monitor the clinical response. Just like when we looked at phenytoin, you're going to monitor the serum concentrations to see if it's effective in preventing seizures or not. Fluoroquinolones or tetracyclines are antibiotics. You're going to see how the patient is responding clinically to the infection. If the infection is worsening, that probably means that they're not absorbing as much of the antibiotic. Warfarin is another drug I don't think that you have learned about yet. Have you or have you not? No? Okay. So it's another anticoagulant I'm sure you've heard of at least. You probably have heard the joke that it's rat poison, which is actually true, but different discussion for a different day. But it is a drug that's similar to phenytoin. It's highly protein bound. So same thing that you give it was the feeding tube that has protein. It will bind to it. Your body's not going to absorb as much. Now your risk of clotting is going to significantly increase. So what do? Hold the tube feed, give the drug, hold the tube feed, then resume it again. Warfarin is also another narrow therapeutic index drug. We don't monitor concentrations of warfarin like we do with phenytoin, but we monitor the effect, the therapeutic effect of warfarin by measuring INR, or international normalized ratio. You want it to be within a certain range based on what condition you're treating. So you monitor that to see if your body is actually absorbing enough. Proton pump inhibitors, they're not exactly, their PK and PD is not exactly effect, but it's more that they do decrease the acidity they do decrease the acidity by decreasing acid production, which is important for the absorption of certain drugs or bypassing the stomach for other drugs that need to be enteric coated. So that becomes a problem. The other problem is most of these drugs are enteric coated actually. So if you try to crush it to stick it into a feeding tube, that drug is not going to work. So you need to be mindful of that fact that you're using a formulation that can be given in a feeding tube, such as granules or liquids, and to be mindful also of the fact that granules usually clump up and clog the feeding tube. So something just to think of when you are planning therapeutic interventions for these patients. And lastly, levothyroxine. So levothyroxine is another drug that you're going to see very often in your clinical practice in an inpatient or outpatient setting or whatever practice setting that you use. It's because hypothyroidism is a very common clinical condition, unfortunately. And levothyroxine is a drug that can bind easily to the tube feeding. The feeding itself while it's in the tube or even in the intrahepatic circulation when it gets cycled through the hepatic cycle. So what do? You generally, again, hold for about an hour or so before feeding, then hold for another hour after. Oh, sorry, hold the feeding for an hour, give the drug, hold for another hour, then resume feeding. Levothyroxine, you kind of do the same thing when patients are taking it orally. Actually, you ask your patients to take the drug first thing in the morning on an empty stomach and wait for another hour before they take anything. Levothyroxine, similar to fluoroquinolones and tetracyclines, can chelate with cations as well. So you tell them to avoid taking it something closer to something that might have some in it. So generally, the strategies are very similar. Alternatively, you can try to give levothyroxine as an IV if you can't really give it in the feeding tube. The common theme in this slide is, as you can see, that we try to hold feeding for some time, give the drug in the middle and hold and then resume again. But what you need to think of is that some of these drugs are given twice a day or 3 times a day or 4 times a day. Are you going to be able to hold for that much? And in the periods where you are running the fluid, the enteral nutrition, is that going to be enough to give the patient the entire amount that you need? Maybe, maybe not. So keep in mind that the interruption for about 1 to 2 hours, as the box at the bottom says, 3 to 4 times a day, that can actually result in inadequate nutrition support because there is no way that you're going to be able to squeeze in the exact amount of nutrition that you need and your patient is going to tolerate it. Because remember, again, you're pushing a lot of volume in a shorter period of time, so they might not be able to tolerate it. They might start having nausea and vomiting and a lot of that fluid accumulating in the stomach rather than passing through the intestine. So let's check our knowledge for the last time. We have a patient who is a 65-year-old male coming into ICU with a small bowel obstruction. The patient has been receiving levothyroxine 75 micrograms IV daily for his hypothyroidism. After 5 days of bowel rest, the patient has improved, and the team is now ready to initiate enteral nutrition. The nurse wants to know if she can give IV levothyroxine 75 milligrams at the same time as the enteral nutrition. How should the IV levothyroxine be given? What do you guys think?
D. Answer D.
Okay, I got a vote for B, a vote for D, another vote for D, a third vote for D. Wow, everyone is going for D. Okay. All right, so let's go from the bottom up and see what we think. So D says hold enteral nutrition for 1 hour before administration of levothyroxine 75 micrograms IV and 1 hour after administration. So that answer is actually incorrect. Can anyone tell me what's incorrect about number D?
IV.
IV. Yes. If it's IV, I can give it any time. Remember, the interaction is happening because the levothyroxine is in the same environment as the feeding tube. So if I'm giving levothyroxine enterally, that's the problem. Then I have to hold the feeding tube for an hour, give the levothyroxine enterally, then hold for another hour, then resume it. If I'm giving an IV, I can give it at 9 a.m., 9 p.m., 6 a.m., 3:40, 6 a.m. It doesn't matter. I can give it any time of the day as long as I'm consistent, obviously, from one day to another. So option D is incorrect. Option C says discontinue levothyroxine until the patient discontinues enteral nutrition. Not practical. The patient needs his levothyroxine replacement, otherwise he will be in hypothyroid condition. So the answer is no. How about B? It says hold enteral nutrition for 2 hours before administration of levothyroxine, then give enteral nutrition immediately after. So that's wrong for several reasons. Number one, it's IV. Number two, it says give enteral nutrition immediately after, which if we're giving it P or enterally, then you would still need to hold it for another hour. And obviously the first number should have been 1. Lastly, option A, it says levothyroxine 75 micrograms IV can be given at the same time as enteral nutrition. And we got a winner, right? Ideally, that's not what we're supposed to do, right? Ideally, if you can give levothyroxine enterally, fantastic. And you would hold enteral nutrition for 1 hour, give the drug, wait another hour, then resume enteral nutrition. But if you can't, then you can use an IV and the timing would be irrelevant. Does that make sense, guys? That's also another tricky question. I will not be that tricky in the exam. So I don't want you to think that I'm trying to, trick you into getting the wrong answer in the exam. That's not going to be the case. All right. That concludes our slides. Again, there are some practice questions, extra bonus questions that I want you to practice and let me know your thoughts. So A is correct. Yes, that is correct. A is the right answer. Let me know your thoughts about the bonus questions. Let me know your thoughts or questions about the material in general. And now please let me know what you think. If you want to do a recitation, you want to do a reiteration of lecture 8 since the recording is not available. If you want to never hear about that material again, ever, I would totally understand, but you'll still have to hear about it in the exam 1 at least. What do you guys want? Who's the class president?
Jessica.
You got called out, Jessica. What
I
do
was raising my hand, but yeah, me.
So what would you advocate for your classmates? It is totally fine if you guys don't want to have a discussion, want to practice things, don't want to practice things. You think you're set for the exam. What do you think?
Yeah, I'll take a poll in our group message, or unless somebody wants to speak up if they want to do it or put it in the chat now. I'm down for a recitation.
Yeah. Only if you guys need it, obviously. Just keep thinking
Right.
I appreciate you planning a poll, Jessica. And I didn't mean to call you out like that, but
No, you're good. Yeah, if we want to do it in the group message because nobody's sending anything,
okay.
I will let you know.
Okay. All right. And again, the option is available. If you do have questions, you can always email me. You can, we can have a meeting via Zoom or anything like that. So I understand the material can be a little bit complex and needs a little bit of digestion. No pun intended, actually. But yeah, got a vote for recitation from one of your classmates. So please, Jessica, I'll appoint you as the contact person here to let me know and include Dr. Foles, please.
Okay.
All right, guys. It's been a pleasure seeing you again, teaching you again. Hopefully, you guys have gained some knowledge from this series that would be helpful for your future practice and your knowledge in Netflix prep in general. I hope you have a good rest of your day. Bye.
Thank you.
Thank you.